This podcast is hosted by Will Glomsky. Will is an experienced critical care paramedic working on a ground ambulance. This podcast is purely educational, and the opinions reflected are of the hosts only. This show is not intended to supersede any local protocol or training. This podcast covers educational content surrounding emergency medical services. Welcome to the Midnight Medic Podcast.
Hello, and welcome back to the Midnight Medic Podcast, the podcast where we break down essential topics in pre-hospital emergency care. I'm Will, and today we're diving into a critical life-threatening condition that EMS providers must recognize and treat quickly, pneumothorax. A pneumothorax, or collapsed lung, occurs when air enters the pleural space, disrupting the normal negative pressure and causing lung collapse. This can result from trauma, such as penetrating chest wound, or spontaneously in high-risk individuals. For EMS providers, early recognition and appropriate intervention are key to improving patient outcomes. Let's start with how we recognize pneumothorax in the field. Signs and symptoms can vary depending on severity, but common indicators include sudden onset chest pain, often sharp and pleuritic in nature, dyspnea ranging from mild to severe, decreased or absent breath sounds on the affected side, tachypnea, tachycardia, and possibly hypotension. In cases of tension pneumothorax, the patient may exhibit worsening respiratory distress, anxiety, jugular venous distension, and tracheal deviation. Both of those last two are late signs, and other signs of obstructive shock. These are true emergencies requiring immediate intervention. Additionally, patients with predisposing factors such as chronic obstructive pulmonary disease or COPD, Marfan syndrome, or previous spontaneous pneumothorax should raise suspicion even in the absence of trauma. Understanding the patient's history can provide valuable clues in making a timely diagnosis. To fully grasp the urgency of treating a pneumothorax, let's dive deeper into the pathophysiology of this condition. The pleuritic cavity is a sealed space between the visceral and parietal pleura that maintains a negative pressure relative to atmospheric pressure. This negative pressure is essential for keeping the lungs expanded and allowing normal respiration. When air enters this space, whether due to a traumatic injury, rupture of the weakened alveoli, or barotrauma, the pressure dynamics are altered, leading to lung collapse. There are three primary types of pneumothorax, each with distinct pathological mechanisms. First up, we have a simple pneumothorax. This occurs when a small amount of air enters the pleural space without ongoing accumulation. The lung partially collapses, but the condition remains relatively stable because the air does not progressively increase. The ineffective lung can typically compensate, and symptoms may be mild unless pneumothorax enlarges. Tension pneumothorax. This is the most critical and life-threatening form, characterized by a one-way valve-type mechanism where air enters the pleural space with each breath but cannot escape. This progressive air trapping leads to increasing intrathoracic pressure, which compresses the lung on the affected side, shifts the mediastinum, and obstructs venous return to the heart. The result is decreased cardiac output, hypotension, and if untreated, cardiac arrest due to obstructive shock. Signs of decompensation include worsening dyspnea, cyanosis, profound hypotension, distended neck veins, and tracheal deviation, though deviation and distended neck veins are a late and inconsistent finding in pre-hospital settings. Last up, we have an open pneumothorax, also known as a sucking chest wound. These are caused by penetrating trauma that creates a direct connection between the pleural space and the external environment. Air potentially enters through the wound instead of the normal airway during inhalation, preventing proper lung expansion. If untreated, an open pneumothorax can evolve into a tension pneumothorax, further compromising respiratory function. Additionally, the body's physiological response to a pneumothorax exacerbates the problem. As the lung collapses, hypoxia and hypercapnia develop due to impaired gas exchange. The body attempts to compensate with increased respiratory rate and heart rate, but in severe cases, this is insufficient to maintain adequate oxygenation. As the alveoli also collapse and inflate, it releases cytokines, which worsens the patient's inflammatory response. Patients with pre-existing lung disease, such as COPD or asthma, are at particularly high risk because their lung compliance is already compromised. Even a small pneumothorax in these patients can lead to significant respiratory distress. Understanding the physiological impact of a pneumothorax is crucial because it underscores why rapid intervention, whether through oxygen administration, needle decompression, or chest sealing, is vital in the pre-hospital setting. Management of the pneumothorax depends on its severity, so let's break it down. Basic life support management can include maintaining an open airway and providing high-flow oxygen via a non-rebreather mask if hypoxia is present. Monitor vital signs closely and be alert for signs of clinical deterioration. If an open pneumothorax is present, apply an occlusive dressing with a vented seal or tape 3 sides to allow air to escape while preventing re-entry. Be cautious with positive pressure ventilation as it can worsen a pneumothorax or lead to a tension pneumothorax. Some advanced life support management can include needle decompression. If tension pneumothorax is suspected, perform immediate needle decompression at the second intercostal space mid-clavicular or the fourth or fifth intercostal space on the anterior axillary line as per protocol. Reassess breath sounds post-decompression and be prepared to repeat the procedure if air reaccumulates. Establish IV access and administer fluids to support perfusion, especially in cases of obstructive shock. Administer appropriate analgesia and sedation if the patient is in significant distress. And finally, expedite transport to a facility capable of definitive chest tube placement. In the critical care setting, definitive management focuses on continued resuscitation and definitive surgical interventions. If allowed, a chest tube thoracostomy, performed in hospital mostly, but sometimes on critical care trucks to continuously evacuate air and prevent reoccurrence. This is typically placed at the fourth or fifth intercostal space mid-axillary line. Some advanced airway management. Patients with severe respiratory distress or poor oxygenation may require intubation with mechanical ventilation. Caution is required, though, as positive pressure ventilation can exacerbate a pneumothorax if not managed properly. Ultrasound-guided assessments, including a bedside fast exam, can confirm ongoing pneumothorax and guide chest tube placement. And definitive surgical management. In cases of recurrent pneumothorax or ongoing air leaks, video-assisted thoracoscopic surgery, or VATS, may be necessary. Pneumothorax is a high-risk condition that EMS providers must be prepared to identify and treat swiftly. Early recognition, appropriate airway management, and timely needle decompression for tension pneumothorax can save lives in the pre-hospital setting. As always, continue honing your assessment skills, stay up to date on protocols, and never hesitate to ask when faced with a life-threatening emergency. Thanks for tuning in to this episode of the Midnight Medic Podcast. If you found this episode helpful, be sure to subscribe and share with your fellow first responders. Stay safe out there, and we'll catch you in the next episode.